centers, and that can really help them not only diagnose, but walk them, what are the next steps? How can you not only try to live your best life with the disease, but push back against the disease? And I think it starts with neurologists and really them buying into that it's not just about, diagnosis and medication, Aricept or something like that. And then obviously standardizing the recommendations and methodology across the state of Ohio. The fourth item would be emotional and tactical support for patients and for caregivers. So if you think about once you have some type of diagnosis, it's emotionally draining on families, it's emotionally draining on caregivers, and then creating some type of methodology of tactics, how to keep your loved ones safe within their own environment, independent as long as possible. And there's ways to do that. And once again, that's just about having easy access to support groups for both patients and caregivers, and then great information on how you can transform your own environment to support somebody with dementia. And then a huge aspect is the mental health support for also patient and caregivers. We often see the caregiver pass before the person with dementia, just because of the emotional and physical drain that it puts on their body. And so we really feel that there should be a major support system when it comes to mental health. Mm-hmm. The fifth touch point is clinical support for patients. So increasing from diagnosis to brain optimization plans and everything in between. So I just don't think that right now you can go and really get the right information to really guide you through the process. So I'm thinking that if the state can create sort of a best practices platform that somebody, searching for, okay, mom has a diagnosis, now what I do, they could click on the state website, and that platform can actually guide them through the methods, the support, the equipment that's out there. And then in support of that, it might be interesting to have sort of state certifications for the clinical side of things, where maybe you have to get a certification for early detection, and it's not only talks about the process, but it talks about methodology, it talks about the equipment that's out there and can be used, the different types of testing, from blood testing to cognitive view to whatever the platform is, but sort of standardizing on that and creating some type of certification platform. And then support and other things. So I'd like some input on if y'all are into state certifications. I think there could be some benefit there, or maybe it's not so much state as it is partnering organizations that could do certifications like that. And then the final touch point, I think, is right now, if you really want to push back against cognitive decline, most brain wellness programs are private pay. And I really would like to see that similar to how we do, chiropractic services and health and wellness checkups. We should have insurance policies that cover those types of things for brain health. And so if it's diagnosis through brain optimization plan, I would love to see health insurance cover those programs. I mean, really, like the out-of-pocket costs to get a brain optimization plan, it ranges anywhere from $3,000 to $6,000. So it's not extensive, but it can make all the difference. And if somehow we can get that put on an insurance plan, that would be, I think, beneficial to Ohioans. And that sort of brings me to the bottom of this. And then Tina had put together, let me see if I can share this.
And Greg, I just want to hit on too that we kind of talked about we all kind of overlap on the education part, I think, and how the education should be provided. But one thing I think that could use some help is how we educate, especially staff members. I think we assume that just sitting through a course is going to be enough. But what I've noticed over time is a lot of STNAs, not so much nursing, have a trouble grasping what's on the PowerPoint or what's on the computer, but they do well when they're more hands-on. So when I started integrating sensory stuff upstairs on the unit, they fought me for so long. But once they started seeing the benefits of the weighted babies or the environmental changes, then they saw that, hey, this helps with my care. So I'm going to keep helping decrease these anxiety. So I think on an education point, I think we'd have more success if we somehow get more interaction and hands-on towards the education.
Yeah, I couldn't agree more, Tina. I think that, the concept of static learning, and that's kind of where the state's been. Like, there's a few places you can go, you can grab some information. And I know that being in those communities, the acquisition of knowledge is just not there. It's sort of like, yeah, I know that, but then the practice is contrary to the knowledge because they really haven't integrated it. So I completely support that. I'll also add that I think the idea of having a standardized platform where it's really from this step to this step to this step, I think ultimately my hope in being a member of the task force in general is that we come to that place, because I think as a clinician, the biggest pain point for me over 30 years has been watching families go through exactly what you just described, Greg. You have resources at your disposal and knowledge at your disposal, and yet that story is all too often every single day somebody comes into my clinic and that's their struggle is, we were told that he has dementia as we were walking out the door of the exam room, and we have no idea what we're supposed to do. Is he going to die tomorrow? What do we? So I think the best service that we as a task force, at least my bent as a clinician, is to be able to provide here's where you go. Because it's a grieving process, it's a struggling process, and we just dropped the ball there in general. There are places that do it really well and places that do it terribly. And I think if our task force can somehow standardize that, with all of what you just said, and Tina, you bringing in the very important, I think, piece of education cannot just be sitting in front of a computer for 45 minutes and gathering static information, because it's never going to translate into the comprehensive, complex care that is required. So.
And real quick too, Greg, and Greg did a great job doing our whole entire presentation. He hit every point good. But another thing I was thinking too is I think we wait too long with the cognition. Like, we'll say my grandma was slurring her speech or walking with a different pattern. They don't identify dementia at that point. They wait until it affects their entire environment, like when they start seeing the signs of, oh, mom can't bathe anymore, mom can't eat, mom can't. But we need to teach them that when they start having declines in their speech and ambulation and functional abilities in the home, that's an early sign. So then 6 months later, they don't go down the road, and then they hit into this wall. Well, mom has dementia and she needs 24-hour care. But I think it's better education on those beginning pieces too.
Yeah, completely agree. All right, I'm looking at the clock here. Is there anything else from Greg and Tina on this objective?
This is Bonnie. Can I just raise one question? And I am, as you know, I'm not a clinician, but throughout our discussions and every discussion that I participate in, people tend to use the concept of disease of the brain and mental health issues almost interchangeably. And I think that we somehow will have to, or our state would benefit if we clarify that this isn't a mental health issue. On the other hand, we have, a lot of national organizations that are saying it is, and I struggle with that.
Yeah, it's a great point. And I think as a psychologist, I would add that I think the language we use drives the process of what we do next. And I know beyond the scope of our meeting this morning, but I think because mental health has always had kind of that negative connotation of like, well, if you're medically ill, and you can almost hear the inflection, then we could do this, mental health. And yet we're talking about a holistic being, and it's neurologically driven. Everything starts in the brain, whether it's, mental health issues, neurological conditions. So I think it's a great point, and probably one that our committee will have to grapple with, so that we're really clear about the language that we're using, because the language drives the care planning. I'm sorry.
Yeah, I agree.
Okay.
Thank you.
Totally agree with Bonnie. I think the removing mental health will be super helpful, to be frank, because I think it just complicates the issue in some ways, but it also is a falsehood in leading on others to believe that it is a mental health issue. And I've received that even from members of the General Assembly who are summing it up as a mental health situation or mental health issue, or saying, well, we've addressed mental health, and dementias, they're kind of lumping dementia in that category. So the less we can use that term probably is the better, for the sake of the issue that we're working with, was Alzheimer's and dementia.
So I think
And I push back a little bit, that mental health is the same. It should be also treated not as, let's hide it under the rug because we don't want to talk about them. We don't want dementia to be fit into that ugly category, but mental health, physical health, spiritual health, brain health, body health, it's all one. And I think I would hate, again, as the psychologist here, hate to see us go, we want to separate ourselves from that word, because on the other side of that is people will identify, well, my loved one is just mean, is just saying nasty stuff, and because they're anxious and they're nervous, and what they're really talking about is dementia symptoms. And so I agree. I think there's a lot of ways that we're going to have to grapple with that, and that might be another important component that comes out of the science committee, is how are we using these terms so that they're medically accurate and that the connotations are addressed around those issues. Because I agree, Trey, the idea of them going, well, we address mental health, therefore dementia just kind of gets lost in that general category, is not going to serve us well. On the flip of that, writing off mental health like it's, the thing that we should avoid doesn't help us either. So great.
Yeah, I think it's all in how we frame mental health. I think it's important to have it in there. It's necessary for a holistic approach, but it's how we frame it.
Yeah, agreed.
And you also can't deny the fact that there are many, many people who their initial presenting symptoms of their dementia is going to be the neuropsychiatric symptoms. They're going to be depressed, new onset anxiety, the agitation, hallucinations. And so it's definitely key, even in a diagnostic process, to recognize that those are often early symptoms of dementia. Yep. Saying, they're just depressed, or they're just anxious, really limits that early diagnosis for a lot of people. Right. Yeah. So I agree. I think teasing that out and how to present that without, being super technically and all that kind of stuff in our language is going to be a challenge.
Yeah, I agree. I think it's one of those things we may want to even just try to flesh out, how do we leverage everything we just said, but kind of use it in a way to kind of get where we need it to go. And really, I think it's just the term mental health. I think some policymakers sometimes automatically assume that it's their iteration or their thought process of mental health and what mental health is, whereas some of this is merely symptoms of dementia. So it's like, how do we frame it in such a way that it's favorable to our outcome, I guess is what I'm trying to say.
Absolutely. I completely agree. So I made a note of that, because that will be maybe one of our other threads that we'll pay attention to as we create this pull-through platform. Okay, so for the interest of time, then let's turn this over to Bonnie and Jennifer. Would you go by Jen? I'm sorry.
Yeah, typically.
Okay, Bonnie and
Jen,
Jen.
you want to take the lead?
I think did I present? Is it sharing now?
Yes.
Okay. I don't know, Bonnie, do you want to get started? Or do you want me to?
No, why don't you? Because you can answer any clinical questions, if you don't mind.
All right, so our group was identifying gaps in current state of interventions, healthcare, and those long-term care settings to successful implementation. So one thing, certainly that long-term care settings, one thing we were talking about is really needing to focus on being inclusive of not only like a facility-based type of long-term care, which I think a lot of people initially think of when they hear that term, but really focusing on the long-term services and supports, whether that's facility-based or in the community, just focusing and being thoughtful on that language.
And as we've been talking through this, certainly a ton of overlap, and the key to any intervention is to really understand what you're intervening on. So it comes back to that early diagnosis. So limited understanding and training of primary care physicians on the evaluation and diagnosis and the potential interventions available for folks living with dementia. A lack of awareness of those early signs, whether that's recognizing the slow changes in the ability to maintain independent function, whether that's the onset of depression or anxiety, as we already talked. Those early signs aren't necessarily what you read in the book all the time anyway. They're definitely much more varied. Oftentimes, right, there's not really a diagnosis that was made or received or remembered. You give that diagnosis maybe to somebody who has a cognitive impairment, and by the time they get home to share that information with their loved ones, if they do at all, a lot of the details may be lost. But probably more often than not, it's kind of as we've already said, that you probably have dementia, and here's a medicine for it. Effectively communicating what that diagnosis is, what it means, and in a way that the individual and their family understand it's important. And then actually, I think some challenges in the diagnosis itself. We're talking about standardizing screening tools, but they are screening tools, and they're not designed to be a diagnostic tool. And taking that screening tool and transferring that to people who have the expertise to make a diagnosis, be that neurology, geriatricians, neuropsychiatrists, all of those are certainly limited resources with a growing population of people who are in need of that evaluation. A lot of challenges with the definitions, the dementia, delirium, mild cognitive impairment, dementia. I hear that often still. It's you have a vascular dementia or a Lewy body dementia, and that oh my goodness, at least it's not Alzheimer's. So that lack of awareness of the differences. But I think that also translates into the clinical side of not recognizing those differences. And then awareness around, trusting a diagnosis. These diagnoses are still generally, particularly in the in the majority of communities, are made up based on clinical assessments, and there's not a definitive test that's readily available for everybody who needs it. Certainly, they've made a lot of progress with more advanced imaging tools, but still, questions I think regarding that. Treatment management and follow-up after diagnosis. As we've said, a lot of lacking education, that where to go, what to expect, how to value and capitalize on the individual's ongoing strengths, and sometimes only seeing this diagnosis in forms of the weaknesses or challenges. What are the risks points, and how do we work to decrease the risk of harm for individuals? The medications to treat both the dementia and the neuropsychiatric symptoms, the risks and benefits of them. Right, there's not a lot of effective medicines. They have risks and side effects themselves, and limited awareness or support for non-pharmacologic behavior management as well. And then what does that community supports look like? As we've said, that information that is provided isn't empowering, and families are really left feeling like, it's a black hole, and there's nothing that can be done. The decline is inevitable, and I think that filters back into the clinician sometimes. Is really how do we interact with this person? How do we interact with their patients and families when we see that future versus maybe focusing on where they're at, and again, their strengths at this point. And no intervention to assist the caregivers who are often really struggling with this. And I think, as Lori said, really grieving the loss of that person, even that anticipatory grief type of thing. We've talked about consistency, across the state, county to county, and what resources are available due to lack of consistent public funding, clinicians and other providers. So I want to make sure that, this training, we're talking about primary care or, physician clinicians, but certainly, needing to focus on kind of the rest of the healthcare team, nursing education, physical, occupational, speech therapy education in the care of those living with dementia. Clinicians often not aware of the community resources and how to access them. So how do we, transfer that information to patients and their families? We talked about the reimbursement and insurance coverage, limited amounts of time, shortages of specialists to work with those living with dementia, and then kind of a soapbox of mine sometimes, but the concept of ageism. You have that often sense, you hear that, oh yeah, I'm just getting old, my memory, I'm just, memory, the senior moments, those sorts of things. And certainly there are cognitive changes that occur normally as you age, but how much of this is perceived as that kind of inevitable or normal part of aging. And so that slowing down the diagnostic process, or delaying it, or that other side of expecting everybody over a certain age to get dementia. And so why, from a public health standpoint, like, why should we worry about it? It's just going to happen anyway. And then the cultural components of interpreting dementia and symptoms within the race, gender, ethnicity, religion, social settings of folks. Feel free to jump in, Bonnie. So for the long-term care issues, again, maybe community-based long-term services and supports would be language that we could think about using a little bit more. Application of evidence-based programs is limited by access. Again, that variability from county to county, city to city. The public perception, lacks of training opportunities and awareness within communities, kind of pulling in some of that like dementia-friendly communities language in there with shopping, transportation, arts, leisure activities. How do we continue to encourage and engage people who do have a diagnosis of dementia into those types of activities versus, the first time, mom is unable to sit through a concert, even though that's something that she loved, we hide and squirrel them away. Looking specifically toward facilities, memory care units, whether that's long-term care or in assisted living types of facilities, kind of lack of state regulations from standardization of what those units may look like, including staffing concerns and education concerns. And we did throw out this question regarding, should patients with dementia be housed separately? And if so, if they should, how are we ensuring that the care that they're receiving is something that is unique and specialized to their needs in order to be in a memory care unit versus just a place, again, that's kind of behind the closed and locked doors. And then end of life. So we pulled in some end of life care. Oftentimes the diagnosis being made too late for effective advanced care planning that really incorporates that individual and their goals and wishes. A lot of presumption that people who have dementia automatically aren't capable of engaging in those conversations, making sure we're treating, assessing for pain and those behaviors. Caregiver concerns again, and we had a note in here about the recognition that veterans with dementia often have different patterns associated with their post-traumatic stress disorder, and needing that trauma-related, trauma-informed type of care as well in order to effectively care for them.
Wow, that's great. That's a lot of good information in there. And I like the idea that you've incorporated end of life, because I think your point is critical when you talk about that should be happening upstream. We absolutely should be talking about long-term care planning, end of life care planning early in this process. I think it gives the patients a better sense of control and they have a voice. I certainly know doing a lot of capacity evaluations at the end, their choices are taken away from them, that we really want to be able to encourage, once the diagnosis, they're beginning to make some care planning themselves, including how they want the end of life care to go. So I think this is great. And we have 5 minutes as a quick wrap up here. So my suggestion is now we have to figure out a way to consolidate. Again, once again, we took those diamonds, we broke them down into our 3 general buckets. Now we have to take our 3 general buckets, I think, and whittle that down into a workable document that then we can look at, okay, these are our objectives, and then how will we know what will be our benchmark to measure the success of moving that forward. So I think the next step has to be taking these 3 categories and looking for overlap, and then dwindling that down into a tighter document. Because I wish we had like years and decades to work on each of these very important identified tasks, but I think we have to be mindful of the time that's ticking, that we have to produce something by August. So does anybody want to make a suggestion about how we do that? Either we do this individually, we break into our groups again to try to work on each other's documents. I'm open to any suggestions or advice on how we might want to keep working through the document.
Yeah, I think maybe in looking at, I think we go back to our groups and just try to zero in on maybe a couple of key items or key things, and probably consolidate some of the other bullets and try to figure out how we can consolidate as best we can. So when we present it and put it all into one document, it's not sort of as long, and it's actually actionable to some degree. And it's not too robust. It's just my initial thoughts.
Yeah.
So how do we get to the consolidation?
Yeah, I would say maybe we go back to our groups this week and then consolidate within the group, and then upload the consolidated form maybe in a Google Doc or something.
So
Based
when you
off
say
category.
when you say groups, Trey, you're talking about the dyads, the 2 of us working together.
Yes. Sorry about that. Sorry for yeah.
And then we'll be back together as a group, and maybe putting it into the Google Docs that we can see. Because one of the things I'm imagining is each of us are going to have education as one of the core elements, and we're all going to have education in the very specific way that Tina talked about it, where it's not just we need more passive information on the internet. So we already know that that's going to happen, maybe through a shared document. We can, again, depending on people's comfort. I know some people are not comfortable in working on a shared document that keeps moving figures around, and I'm open to any suggestions on that, but I agree. I think we want to be able to flesh this out individually in our subgroups, but also that we can each see what we're doing. Because if we're working on one and we're really building it out, and Greg is doing the same thing in his team, I think we're duplicating.
Yeah, we're fighting against one another.
Yeah.
So I guess first of all, maybe everybody shares their document with me, and then I'll distribute that so everybody has a copy of all 3 documents. You can obviously review that. So it almost makes sense for one group to maybe start vetting through it, and we can track like changes maybe. I don't know. What do you like? How is it going to just be pushed into one document? I don't, like you said, I don't want.
Exactly, Greg. But yeah, I agree. I think, when I look at this at quick blush of what everybody's presented, I could already see 3 primary trends that surfaced in the notes I was taking. One is education. And that's education of staff, whether it's physicians, whether it's care providers. It's a very structured way of looking at education. And then the other one came up about family education, which ties into early detection, the identification of those symptoms.
Lori, would you and Greg maybe be able to, because you're really good at this, look through these and just come up with kind of what do we all have in common here, and just kind of put them in buckets, and then we can respond? Maybe.
Yeah, I'm happy to do that too. Yeah.
I think that's good. I think, let somebody start with it and then everybody respond to it.
Okay. All right. Well, then I'll take a quick pass at it, and I'll share it out with Greg and Trey, and maybe the 3 of us will come up with like really tight, and then we'll put it out there into a shared document that you guys can look at and go, you guys forgot this one. How do we dovetail that in? So everybody in agreement with that is the going forward plan, the homework assignment?
Yeah, so we're not actually meeting next week. We're meeting with the main group the task force on the 26th. So we won't actually meet as a science committee till the following Monday, just so
Okay.
you know that.
Thank you, Greg. And then that gives us the extra week, but I'm going to jump on this and get my initial thoughts and pull some of this together of what we heard today, share it with Greg and Trey, and then we'll tweak it tightly and then get it out to you guys so that over the course of the next week you can keep looking and adding, and we'll put it in a shared document.
Thank you.
We are at 11 o'clock.
We are at 11.
Do I have a motion to adjourn?
So moved.
Yes. You have a motion.
All right, very good. Thanks everybody for all the work, and we'll see you guys next week and then again in 2 weeks.
Bye.
Take care.
Thanks.
Bye-bye.
Bye-bye.